Can you hear me now? Okay. We are going to talk about Neuro of Thermology and just to revise the structures of the orbit. Uh, this thing is concerned, your injuries are concerned. Okay. So the bones that make up the orbit are maxillary, zygomatic, frontal, acromial, sphenoid, palatine, and ethmoidal. Okay. Through several bony canals and fissures. So all the blood vessels coming in from the brain to the orbit and leaving the orbit going towards the brain are all going through these foramina. Okay, so posteriorly the cavernous sinus is connected to the orbit through the superior orbital fissure. Okay, the medial wall of the orbit, as we know, the lateral wall of the sphenoid bone, is connected to the nasal sinuses. When sharp objects enter the medial orbit, they are directed through the superior orbital fissure where they can lacerate the carotid artery. Okay. Now the orbit is connected superiorly and posteriorly to the anterior cranial fossa by way of the optic canals, which transmit the optic nerve, the ophthalmic artery, and the sympathetic fibers. Inferiorly at the apex, the orbit is connected to the pterygopalatine area and thus the temporal and infratemporal regions to the inferior orbital fissure. Now, a little bit about the vascular anatomy. This is just a revision to refresh your mind before we start talking about the neurology. Okay, so the arterial system, the common carotid arteries arising from the innominate artery on the right and directly from the aorta on the left supply most of the blood to the skull and its contents, including the orbit. The venous system is ocular venous outflow begins in the arcade retinal veins into the central retinal vein and in the choroidal veins which exit the sclera through the vortex veins. If you remember when we talked about sclera, we talked about the vortex veins. Anteriorly, the episcleral venous plexus collects both blood from the anterior uveal circulation and aqueous percolating through the Schlemm's canal. We talked about this also as far as glaucoma is concerned. that some of the outflow is by percolation through the Schlemm's canal. Now, we come to the neurology, which is visual pathway. It's a very important topic as far as exams are concerned. There is one question definitely about the visual pathway. Now, afferent visual pathway. Afferent means those carrying the stimuli from the sensory organ to the brain. So now the visual pathway consists of the retina, the optic nerve, the optic tract, optic chiasma, where they cross, we'll talk about this, and then to the lateral geniculate body. Okay. Now the second order neuron is in the lateral geniculate body. And from the impulses go to the visual cortex. So from if you compare it to anything else, it's the sensory end organ to ganglion and to the cortex. So as far as the eye is concerned, the first order neuron is the cone or the rods. Okay, and the ganglion cells. See? Now, from here, the second order neuron is in the lateral geniculate body, and from there to the cortex. Now, the first order neuron are the rods and cones here, and they communicate via the bipolar neurons with ganglion cells. Now, the ganglion cells, the first conducting nerve cell is the bipolar cell of the inner nuclear layer, this part. Okay, so this is still within the structure of the retina. Now, the second order neuron is the ganglion cells. The processes pass into the nerve fiber layer here. From the bipolar neuron to the ganglion cells pass as nerve fiber layer and along the optic nerve to the lateral geniculate body. Now this is the lateral geniculate body over here. Okay. The new cell in the lateral geniculate body, this takes up the impulses, okay, and via the optic radiations, it takes it to the cortex of the occipital lobe over here, which is the so-called visual center. Okay. Now the afferent visual center, disorders. Now disorders means anything in these three neural pathways, if there is any disease or trauma to these, inflammation, that will cause afferent visual system disorders. Okay, so the first one is optic neuritis, inflammation of the optic nerve, optic neuropathy, papilledema or swelling of the optic disc, brain tumors, and strokes. So that's the vascular element. Now, the union of the two optic nerves is called the optic chiasma, this part. Over here, the nasal fibers from both the eyes are going to cross over, while the temporal fibers remain uncrossed. So they're coming from here and they are passing into the optic tract on the same side. Instead of crossing over, they are passing on the same side. Only the medial fibers are crossing over. Okay. Now the optic tract is from the lateral geniculate body, cylindrical bundle of nerve fibers. They run outwards and backwards and posterolateral aspect of the optic chiasma, and they end in the lateral geniculate body. Now the lateral geniculate body is made up of 6 layers of neurons, gray matter alternating with white matter. So it actually looks like this. The neurons of the third order originate in the lateral geniculate body and pass by the optic radiation to the corresponding occipital lobes. Now these have temporal fibers from the ipsilateral eye and nasal fibers from both the eyes. Okay, so crossed over. So this is also very important in diagnosing when there are field defects. Now we go to the optic radiation from the lateral geniculate body to the visual cortex. So they fan out like this. That's why they're called optic radiations. Now the occipital cortex is very different or slightly different from the rest of the cerebral cortex. The occipital cortex around the calcarine fissure differs from this cortex elsewhere. There is a presence of a white line which is called the line of Generi, interposed in the gray matter. So you see this line over here. This is the line of Generi. Can you hear me now? Excuse me. ये आवाज आपको जा रही है? अब इनको आवाज आ रही है, पहले तो नो नो कर रहे थे सब. आ रही है? Okay. तो ये क्यों? If you have any questions, you can ask me in the chat box. Okay. If you want me to stop anywhere, just let me know. Okay. So now we're going to talk about the pupillary pathways. How does the pupil react? The normal pupil. The pupils are normally equal on both sides. We know that. Okay. The size in bright light is from 3 to 4 millimeters, and in slightly dim light or in darkness, it's 4 to 8 millimeters. It limits, what does the pupil do? The function of the pupil is to limit the amount of light reaching the retina. If you look into very bright sunlight, what do you see? You see a blur, you don't see anything. Okay? So the pupil limits the amount of light. When we are in very bright light, then the light is limited and very little light enters the eyes so that we are able to see. It also controls spherical and chromatic aberrations. जो बच्चे ग्लासेस लगाते हैं वो ये बात समझ सकते हैं बेहतर कि जब आप ग्लासेस नहीं पहने हुए होते हो तो what you do is you squeeze your eyes, make pupils very small, and then you are able to see clearly. So that is the function of a normal pupil. Okay? Now the pupils are small in older people than in younger people. They are smaller in hypermetropes, those who wear plus lenses, and larger in myopes. Okay? And commonly smaller in blue eyes than in brown. Okay? Now there is another term where there is normal pupil and then there is anisocoria. Anisocoria means inequality in the diameter of the two pupils, which may be physiological in 20% cases or pathological. So every pathological cause must be ruled out. So we will talk about causes of anisocoria. Okay. Now, the pupil has two positions. One is called meiosis and the other is called mydriasis. So meiosis is abnormal constriction of the pupil. Okay. This can be due to strong light. This can be due to pharmacological elements. It can be due to some disease. Okay. And then there is mydriasis, which is abnormal enlargement of the pupil. This is also pharmacological, or when we are in the dark. Now, the basic principle is that the parasympathetic and the sympathetic nervous system control the pupil. So this is a balance between the parasympathetic and the sympathetic control. So parasympathetic fibers lead to pupillary constriction and the sympathetic fibers lead to pupillary dilatation. Okay, as well as controlling the superior tarsal muscle, the, which elevates the upper lid, smooth muscle orbitalis, which prevents eye sinking into the orbit, and facial and neck cutaneous arteries and sweat glands. Okay? Now, this is the balance between the parasympathetic and the sympathetic system. So, parasympathetic is via the ciliary ganglion and the Edinger-Westphal nucleus. And the sympathetic, the dilation, is via the spinal cord and the superior cervical ganglion. Now, the pupillary muscles are controlled by, the pupils are controlled by two muscles, the dilator pupillae and the sphincter pupillae. The size of the pupil is a result of their opposing forces, and the essential factor being the superior tone of the sphincter. So, normally, our pupil is more controlled by the sphincter pupillae than the dilator pupillae. Now, autonomic innervation of the eye. This is the sympathetic system via the carotid plexus. It comes to the pupillary constrictor muscle, and via the spinal cord and the Edinger-Westphal nucleus, via the ciliary ganglion, it comes to the constrictor muscle. Are we all clear here? Do you understand so far? Yes? Good. Okay. So now the sphincter pupillae is supplied by the cholinergic fibers of the parasympathetic system. You all know that parasympathetic is the cholinergic, okay? And the parasympathetic system through the oculomotor nucleus, the Edinger-Westphal nucleus, and then the ciliary ganglion and the short ciliary nerves. And the dilator is supplied by the adrenergic fibers of the cervical sympathetic fibers. Okay? It starts in the hypothalamus. Now through the medulla oblongata, which is here, into the lateral columns of the midbrain and lateral columns of the spinal cord. The fibers leave the cord by the ventral root of the first three dorsal nerves and run to the first thoracic or stellate ganglion. Now the nerves supply up the neck to the superior cervical ganglion here, then via the carotid plexus into the skull, over the anterior part of the Gazerian ganglion, and pass into the ophthalmic division of the fifth nerve and enter the ciliary nerve to the iris here. Now there are three kinds of pupillary reflexes. The first is the light reflex that we all know about. Okay, when light is flashed into our eyes, the pupils constrict. Okay? The direct light reflex is, it is shared equally by pupils of both eyes. When you flash light into one eye, the pupil constricts, but the other pupil also constricts. That is called the consensual or indirect light reflex. Okay? And then there is the near reflex. When we start to read something, when we bring something close to our eyes, the pupils constrict in addition to convergence and accommodation. Convergence means when the both eyes move closer together. Okay, that is abduct. And accommodation, you have read about it in the lens and in refraction, that the crystalline lens in our eyes has the capacity to increase its focus and be able to read from a near distance. That is accommodation. Okay, so there is a light reflex and a near reflex. And then the third is a psychosensory reflex. A dilation of the pupil occurs on psychic and sensory stimuli. So this is the, if you remember rightly, the reflex to protect our body. So the pupil dilates so that maximum light can enter and we are able to focus. Now, we'll talk about the light reflex. The light reflex is initiated, as we said, in the retina, in the rods and cones. Now, via the optic nerve, it goes, partially crosses in the chiasma and then enters the optic tract, and they part in the visual fibers, and instead of running to the lateral geniculate body, they run to the pretectal nucleus. Okay, so here it's some of the fibers are going to the lateral geniculate body, and the rest of them are going to the pretectal area. Now, new fibers from the pretectal area, that's the third order neuron, travel to the Edinger-Westphal nucleus, which is over here. Okay, so Edinger-Westphal nucleus. From the Edinger-Westphal nucleus, the constrictor fibers run in the main trunk of the third nerve and to the ciliary ganglion here. And they reach the iris via the short ciliary nerves. So you get it? This is the afferent. We'll clear it up. Now the afferent is the retina, optic nerve, optic chiasma, upper end of the optic tract, and into the pretectal nucleus. And the efferent is from the pretectal nucleus to the Edinger-Westphal nucleus via the oculomotor nerve, the third nerve, into the ciliary ganglion and to the sphincter pupillae. So this is the afferent, okay, and this is the efferent, okay. Now direct and indirect light reflex कैसे होता है? अब रेटिना में आपने लाइट फ्लैश की, ठीक है, तो via the pretectal nucleus, Edinger-Westphal nucleus, third nerve, ciliary sphincter, आपका pupil constrict हो गया, ठीक है. Now we have to remember that from the optic nerve, it's crossing over the fibers. Now the fibers are crossing over directly into the Edinger-Westphal nucleus from both sides, from the pretectal nucleus and from both sides. Now from there, the impulses pass via both third nerves, and both pupils are going to constrict. The crossing over is important because it explains the mechanism of consensual as well as direct light reflex. Now we talk about the near reflex. Is this all clear for you? Now this diagram is very important because this comes in the exam. Efferent pathway. Okay, you didn't understand that. Let me tell you. Now, what happens is if once the fibers have reached the pretectal area, okay, this is not going to the optical cortex. This is branching out and ending in the pretectal nucleus. Got it? And from there, it's passing to the Edinger-Westphal nucleus. Okay, and from the Edinger via the oculomotor nerve into the ciliary ganglion and then to the sphincter pupillae. So, do you get it now, Ali? You have to remember this diagram. This comes in the exam. You have to draw the pathway of the light reflex. So this is the pathway of the light reflex. Now the impulses are coming from the retina via the optic nerve, optic chiasma, optic tract, and into the pretectal nucleus. Remember that. From there to the Edinger-Westphal nucleus. Normally, if they would go for vision, they would go to the lateral geniculate body, but these don't. So this is independent of vision, whether the patient has vision in his eye or not, the light reflex is going to be there. You understand? Because it's not going via the lateral geniculate body and the optic fan, okay, into the occipital cortex. It's not going there. It's going directly to the pretectal nucleus and into the Edinger-Westphal nucleus. This is just a reflex via the oculomotor nerve to the sphincter pupillae. So the pupil is going to constrict or react to light even when the patient is unable to see. Got it? Okay. We go on to the near reflex. What happens when we are looking at a close object? It's initiated by fibers in the medial rectus. Now, when we bring something close to our eyes converge. So, the fibers in the medial rectus muscle initiate the reflex. The afferent fibers run via the third nerve to the mesencephalic nucleus of the fifth nerve to the convergence center in the tectal and pretectal regions. Now, this is a bit complicated, but you can understand that from the third nerve, now third nerve is acting as an afferent here instead of an efferent. Okay? Via the third nerve into the mesencephalic nucleus of the fifth nerve. And from the fifth nerve to the convergence center in the tectal and pretectal region. The pathways relate again from the tectal and pretectal region to the Edinger-Westphal nucleus and along the third nerve again. Now the third nerve is the afferent as well as the efferent to the sphincter muscle of the iris. So the pupil contracts. So there is stimulation of the medial rectus. The impulses are taken via the ciliary ganglion into the pretectal area, mediated over here in the fifth nerve nucleus, okay, and then to the Edinger-Westphal nucleus, and from there via the ciliary ganglion into the sphincter pupillae. What is a psychosensory reflex? The stimulation of any sensory nerve causing pain or emotional state or excitement. It first causes a rapid dilation of the pupil and then a second dilation. Rapid in onset but slow in disappearance due to inhibition of the constrictor tone. This is the fight or flight reflex. Now, normally there are pupillary oscillations. When the intensity of light is altered, the pupil contracts, then oscillates rapidly, finally settling down into a condition of contraction, which is slightly less than the peak of the first wave. Okay? Now, there are two different types of exaggeration of oscillation. This is normal under normal conditions. Okay? So, one is hippus. We'll talk about it in a minute. And the other is lack of sustained contraction. You flash light into a patient's pupil, the pupil constricts, and then it dilates again. So under continued influence of light, the pupil contracts sluggishly, but the intensity of light is increased, but slowly dilates with sluggish oscillation. यानी dilate हो रहा है, constrict हो रहा है, dilate हो रहा है, constrict हो रहा है, ठीक है? While the light is being kept constant. अब light को आप नहीं vary कर रहे हो, but pupil vary कर रहा है. This phenomena is dependent on diminished conductivity in the afferent path of the light reflex. So we talked about the afferent from the retina to the either the pretextual area, lateral geniculate body. Okay, and usually in the optic nerve, as in optic neuritis, inflammation of the optic nerve. Now, hippus is a condition in which the oscillations are very large and are independent of the light falling upon the eye. It depends on rhythmic activity of the nervous centers, is not a peripheral phenomena. It is found in association with multiple sclerosis. So I'm going to show you a small video of hippus. Now note pupil. You notice that the light source is constant, but the pupil is oscillating. Okay, have a look again. See, the light source is here and it's constant. It's not changing, but the pupil is oscillating. So now we are going to talk about the efferent visual system disorders, yani from the retina to the occipital cortex. Anything that happens in that area will cause these effects. These are signs. Okay. So if we can identify signs, we can identify the disease. Okay. So now the signs are anisocoria. We discussed this is unequal pupils. Diplopia or double vision. Ophthalmoplegia. Okay. Ptosis. We have talked about that in the lid. Nystagmus, blepharospasm, and seizure of the eye muscles or hemifacial spasm. Now, anisocoria. Isolated anisocoria is usually asymptomatic and incidentally discovered. This could be physiological. We said that 20% of them are physiological. It may be associated with visual symptoms. अगर anisocoria है, तो unilateral photosensitivity हो सकती है with mydriasis, decreased accommodation with Horner's syndrome. Associated features could be, because the pupils are uneven, it could cause diplopia, photophobia. If the pupil is too large, too much light is entering the eye and it causes photophobia. And hence pain, ptosis, or a blur. Now, causes of anisocoria are number one, Horner's syndrome. It's also called oculosympathetic paresis. इसमें क्या होता है Horner's syndrome में? There is ptosis, lowering of the lid, meiosis, and anhidrosis. Anhidrosis means loss of sweating in one half of the face. Okay. Then number two is oculomotor nerve palsy. Pharmacological, often measuring 8 to 9 millimeters. So the pupil is very large when we instill mydriatics like midrasil or like tropicamide or atropine. Okay. Or sometimes in some patients who are sensitive to inhalers, the bronchodilators may also cause slight dilation of the pupil. And then the Datura poisoning. You have read this in pharmacology. The Datura poisoning also causes dilation of the pupils. Okay. Then mechanical. Mechanical anisocoria can be due to acute congestive glaucoma, trauma, surgical intervention like cataract, iris synecdoche, as in uveitis, iridocorneal endothelial syndrome. Okay. Now, tonic pupil. They respond poorly to light, but briskly to a near target. So, if you put light in the eye, the pupil will not constrict so much as if you give them a near object to look at, they will constrict. Now, this is called tonic or antistonic pupil. इसके अलावा autonomic neuropathies like in diabetes, severe afferent system damage, aberrant regeneration of the third nerve, usually after Bell's palsy, Perinaud dorsal midbrain syndrome, and Argyll-Robertson pupil. Now, in Horner syndrome, we talked about Horner syndrome over here, ptosis, meiosis, and anhydrosis. When all sympathetic function on one side is lost, it results in meiosis, a narrowed palpebral fissure, and slight anophthalmos. यानी लगता जैसे आंख अंदर को चली गई है, ठीक है? Due to loss of tone of the Muller's muscle, sometimes associated with unilateral absence of sweating, and the condition is called Horner's syndrome. So there is meiosis, there is ptosis, and there is lack of sweating. The pupillary light reflex is normal. Congenital Horner syndrome is usually associated or caused by birth trauma to the brachial plexus, forceps delivery, etc. Okay. Now these are the signs of Horner syndrome. There is, if you note, there is meiosis relative to this eye. In the left eye, there is meiosis. There is ptosis, narrowed palpebral fissure, slight anophthalmos, लगता है आँख थोड़ी सी अंदर चली गई. And there is unilateral loss of sweating that you cannot see in this picture, but there is unilateral lack of sweating. Okay, so these are the signs of Horner syndrome. So you get this in a SEQ to diagnose what the disease is. You have meiosis, ptosis, and anhydrosis. We also talked about antistonic pupil. Damage to the ciliary ganglion or the short ciliary nerves produces a tonic pupil, which is characterized by poor reaction to light, sectoral palsy of the iris sphincter, and a strong and tonic pupillary reflex to near vision. Now, near vision is not disturbed. Okay? So, this is called light near dissociation. A tonic pupil can be caused by local ocular or orbital processes such as surgery, trauma, lasers, infection, inflammation, or ischemia. So there is poor reaction to light, but a brisk reaction to near vision. Now in Addis pupil, tonically dilated pupil, this is not reacting to light, reacts more significantly to accommodation than to light. Now when the patient tries to look at a near thing, you see that the pupil has constricted. It is caused by infection, inflammation, or infarction of the ciliary ganglion. So bilateral myotic and irregular pupils do not react to light, but they briskly react to accommodation. Tonic pupils can also be due to autonomic dysfunction subsequent to diabetes, chronic alcoholism, Dysautonomias, neurosyphilis, amyloidosis, sarcoidosis, Guillain-Barré syndrome, or Charcot-Marie tooth disease. 70% of the patients are female. And tonic pupils are unilateral in 80% of cases, although second pupil may later become involved. Okay? Now, this is the difference between an Addy's tonic pupil. Response to light is poor, but affected pupil is initially big. Then its normal fellow pupil but becomes smaller over time and remains tonically constricted. Accommodation is slow and prolonged. Now, in Argyll Robertson, on the other hand, accommodation is quick. Light reflex is not there. Bilateral small pupils that do not react to light. This is associated with neurosyphilis. So in here, there is no response to light, both eyes, in both cases. But in Addy's tonic pupil, there is a quick response to accommodation. Argyll Robertson pupil occurs in patients with tertiary syphilis. They are small pupils, pinpoint जिसको बोलते हैं, less than 2 millimeters, that are often irregular. The pupils do not react to light, but the near response and subsequent redilatation are normal and brisk. Okay? Now the next sign, we were talking about anisocoria. Okay, irregular pupils. Now the next sign is diplopia. Now diplopia is the subjective complaint of seeing two images instead of one and is often referred to as double vision. Now binocular diplopia occurs when both eyes are open and can be corrected by covering one eye. Okay? And monocular diplopia persists in one eye despite covering the other eye and can usually be corrected by using a pinhole. It can be unilateral or bilateral. The classification schemes for binocular diplopia include constant versus intermittent and vertical versus horizontal. So the diplopia could be constant or intermittent. It could be vertical, यानी एक image के ऊपर, vertically ऊपर दूसरी image, और horizontal के एक image के बराबर में दूसरी image. ठीक है? Other causes vary from mild inconvenience to a condition with major health consequences. यानी अगर आपके patient को बहुत ज़्यादा strongly दो images नजर आ रहे हैं तो उसको तो पता ही नहीं कि कौन सी सही है कौन सी गलत है. He'll be falling over himself all the time. Okay? Now patients with diabetic mononeuritis complex recover spontaneously in approximately 6 weeks. We see a lot of these patients who have mononeuritis multiplex. One of the extraocular muscles becomes paralyzed, and that's why the patient suffers from diplopia. But it spontaneously resolves with good diabetic control in about 6 weeks. Now, the optical causes can be lens dislocation. You read about this in Marfan syndrome. Okay? In corneal disorders, they are responsive to repair. Now, another thing important is blowout fractures. Have a variable prognosis depending on the amount of tissue damage. So, किसी को घूसा लग गया आँख में, या road traffic accident हुई है, ठीक है? And there is a blowout fracture, like we said, the orbit is made up of 7 bones. Even one bone gets displaced or fractured, the eyeball moves from its primary position, and it can cause diplopia. Central causes of diplopia can have serious consequences, and in the case of primary and secondary tumors, have a very poor prognosis. Now, the third sign is ophthalmoplegia, also called extraocular muscle palsy. Paralysis of the extraocular muscle that control the movements of the eye usually involves the third, fourth, and sixth nerves. Double vision is the characteristic symptoms in all 3 cases. Now, the causes of ophthalmoplegia: congenital, trauma, complications of viral infection, disorders that affect the nervous system, including MS, cerebral tumors, migraines, vascular diseases such as associated with diabetes, can also occur as a complication of muscle disorders such as myasthenia gravis, although it is usually associated with other muscular symptoms also. Okay? Now, the fourth sign is ptosis. You have read about ptosis in lid. Ptosis is defined as an abnormal low-lying upper eyelid with the eye in primary gaze. The normal adult upper lid lies 1.5 millimeters below the superior corneal limbus and is highest just nasal to the pupil. Causes of ptosis, can be classified as congenital or acquired. The more comprehensive classification is based on etiology and includes biogenic, aponeurotic, neurogenic, mechanical, traumatic, and pseudotosis. The most common cause of congenital ptosis is myogenic due to the improper development of the levator muscle. Now, a very important topic. This is the fifth sign of efferent loss. It's called nystagmus. Nystagmus is a periodic, rhythmic, ocular oscillation of the eye, of the whole eye. It may be sinusoidal and of approximately equal amplitude and velocity, angular nystagmus, or more commonly with a slow initiating phase and a fast corrective phase. So this is called jerk nystagmus. It may be conjugate or disconjugate, equal in both eyes or unequal. It may be horizontal, vertical, torsional, or any combination of these. It may be congenital, most commonly it's congenital, or acquired. When acquired, it most often is caused by abnormalities of vestibular input. Congenital forms may be associated with absent visual pathway abnormalities. Nystagmus occurs because of a disturbance in the sensory motor apparatus controlling normal binocular position. Now watch this video carefully. Now you see these rhythmic movements. This is nystagmus. So this was nystagmus. Now, what is the mechanism of nystagmus? Foveal concentration of of an object is necessary to obtain the highest level of visual acuity. You have to fixate on an object for best visual acuity. Three mechanisms are involved in maintaining foveal centration of an object: fixation, vestibulo-ocular reflex, and neural coordination. Now, what is fixation? The visual system's ability to detect the movement of a fixated image. डिटेक्ट यानी अगर कोई आप ऑब्जेक्ट को देख रहे हो और वो ऑब्जेक्ट मूव करता है तो आपकी आंखें ऑटोमेटिकली उसके साथ मूव करती हैं and signal an appropriate corrective eye movement to refix the image of regard. The vestibular system is intimately and complexly involved with the oculomotor system. How? The vestibulo-ocular reflex is a complex system of neural interconnections that maintain fixation of an object during changes in head position. यानी आपका सर जितना भी हिलता है, we are still able to see the object while when you're sitting in a car, in a moving car, you're still able to look at stuff outside, although it's passing by at about 100 kilometers per hour. The receptors of the vestibular system are the semicircular canals of the inner ear. Three semicircular canals are present on each side: anterior, posterior, and horizontal. And these respond to changes in angular acceleration due to head rotation. So your ear function is very much associated with your vision. Neural coordination: when the eye is turned in an extreme position in the orbit, the fascia and ligaments that suspend the eye exert an elastic force to return towards the primary position. To overcome this force, a tonic contraction of the extraocular muscles is required. A gaze holding network called the neural integrator generates the signal. The cerebellum, ascending vestibular pathways, and oculomotor nuclei are important components of the neural coordinator. So all this together is being able for you to see something, whether it's stationary or it's in motion. Now, this is a very long classification, and this is where we'll end today. It's based on etiology. It can be physiological or pathological. Physiological is usually end gaze, optokinetic, vestibulo-ocular reflexes. Pathologically, it can be congenital, infantile manifest, idiopathic, albinism, aniridia, Leber's congenital amaurosis, bilateral optic nerve hypoplasia. So all these are congenital conditions. Okay. Then it can be acquired. Secondary to vision loss, toxic or metabolic due to alcoholism, lithium poisoning, barbiturates, phenytoin, salicylates, benzodiazepines, anticonvulsants, sedatives, okay, thiamine deficiency. It can be due to neurological disorders and non-physiological or functional. It can be classified as based on pattern of manifestation. It can be manifest, latent, or latent manifest. Then based on direction of movement, horizontal, vertical, or rotary, like we talked about. Based on patterns of movement, it can be jerky or it can be pendular. Now, clinical features: nystagmus is a to and fro movement, defective vision in spite of correction of errors of refraction. Oscillopsia is a perception of the environment appearing to oscillate horizontally, vertically, or torsionally. Absent in children less than 8 years of age. It is present in adults. What is latent nystagmus? There is no movement when both eyes are open, but nystagmus is elicited, increased when one eye is covered. The deviation is bilateral, but may be asymmetric. Occurs in children with strabismus or decreased vision in one eye. Nystagmoid jerks. They are larger, rhythmic jerking movements, more pronounced at the extreme limit of normal movements of the eye. It is not true nystagmus. It occurs in normal people in fatigue. Now, what is the differential diagnosis? There are a number of ocular motility disorders which occur in childhood and resemble nystagmus. These include flutter like oscillations of the eye, ocular bobbing, ocular dysmetria, opsoclonus, ataxia, and ocular myoclonus. How do you evaluate a patient of nystagmus? You take history, age of onset, presence of oscillopsia, the sensation that the surrounding environment is constantly in motion when it is not, history of strabismus or amblyopia, history of previous treatment with drugs or alcohol use, associated symptoms such as tinnitus, vertigo, numbness, motor deficits, or diminished vision, occupational or family history, complete ocular examination, albinism, extraocular movements, visual fields, drug levels in the urine, physical examination to rule out diseases of the CNS, NCT, or MRI as needed. Treatment. Optical aids such as spectacles, prisms, and contact lenses. Medication acquired pendular nystagmus, response to gabapentin. Surgery to reduce nystagmus and eliminate abnormal head posture. And we treat the underlying cause. Amblyopia is treated by either occlusion or penalization. Now we'll stop here, okay? And I just want to tell you, uh, can you see this? Okay. Uh, how to examine the pupil? This is the practical guide. There are three parts to properly examining the pupil. Check for pupil size in light and dark, looking for difference in size. Check for reaction to light in each eye separately. Check for relative apparent pupillary defect. We'll talk about this tomorrow. Okay. Normal pupils are therefore pearl or no RAPD. Pearl stands for pupils equal and reactive to light, and no relative afferent pupillary defect. I think we'll go into this tomorrow after we've studied relative afferent pupillary defect. Okay. Okay, thank you everyone. I hope you had no problems. If you have any problems, please write them down and we'll discuss it tomorrow. Okay, thank you. Allah Hafiz.